Hi, everyone. Thank you so much for joining today's webinar. My name is Hannah. I'm the coordinator for the National Pulse Paradigm Office. Our presentation today is Patient and Surrogate Preferences on the Massachusetts Medical Orders for Life-Sustaining Treatment Form. Today we're taking questions and also comments at any time during the presentation, so please type them in the chat box and we will respond to them. Our presenter is Dr. Chen. Dr. Chen is an Assistant Commissioner for Healthcare Licensing and Quality at the Massachusetts Department of Public Health. She received her PhD in gerontology from the University of Massachusetts, her MBA in multinational management, and her MPH in health policy from the Harvard Chan School of Public Health. Dr. Chen has served as a CEO of biotech companies, as president of a healthcare professions school, and president of an outpatient network of eye care providers. Her research focuses on populations with late-stage multiple chronic illnesses. Her body of research on MOLST was conducted with colleagues at the University of Massachusetts, Boston. I'd now like to bring in our presenter.
Thank you very much for that introduction, Hannah. This is Elizabeth Chen, and welcome, everybody. I understand that we have participants as close as Massachusetts in Boston, near where I am, and as far away as Hawaii. So welcome, everybody, to this webinar. First, the disclosures. I have no relevant commercial relationships to disclose. I am now Assistant Commissioner at the Massachusetts Department of Public Health, and I do have responsibility for the MOLST program. This research was conducted and analyzed prior to my becoming Assistant Commissioner, when I was and continue to hold an appointment as a researcher at the Gerontology Institute at UMass Boston. I'd like to recognize my collaborators. These data could not have been available without my clinical collaborators at Partners Healthcare, at the Dana-Farber Cancer Institute, at Newton Wellesley Hospital, and at Spalding Hospital for Continuing Care. In addition, the senior author on this paper that's under review is Jan Muchler at the UMass Boston Gerontology Department. My presentation objectives are to share data and results from 300 MOLST gathered from 2012 to 2014. This is a subset of data from a larger study. The larger study is composed of 3 locations. The presentation I make to you today is extracted from the Longterm Acute Care Hospital, and the reason I did that is because it provided us the largest variation, the most variation in the outcome variable. And we did incorporate select information from corresponding patient medical records. I will, at the end of the presentation, talk about the implications of this study for policy and practice. This is a picture of the front and back of the Massachusetts MOLST form. Our form is printed on very, very pink, fluorescent pink paper. It is a non-conforming form, non-conforming to the National Pulse Paradigm. On the first page, we have the CPR, we have ventilation, we have CPAP, preferences for CPAP, and preferences for transfer to the hospital. We do require that this first page is signed by a patient as well as the clinician. It allows for some optional information at the bottom. This first page is required for the form to be valid. Now, the back of the page is not required, and therefore we have a lot of missing data there. And so the data from the back of the page are not incorporated as part of this presentation. So the back of the page allows patients and clinicians to specify, for example, the duration of intubation and ventilation, the duration of dialysis, the duration of artificial nutrition or hydration if that's what the patient wants. And it allows a few more lines for other specifications and instructions for patients. And again, the back requires a separate signature by both the patient or surrogate and the clinician who held the conversation. Again, I just want to note that since the back is not a requirement, we really only have data for the resuscitation preferences, which rests on the front of the page. This is the pattern of responses in our long-term acute care hospital sample. You'll see that we have we had 288 responses. We had 288 completed MOLST forms. Some MOLST forms were discarded in the process because they were missing one, either the clinician or the patient signatures. And if that was the case, then they were rendered invalid forms. So our discard rate was actually, let me recall, our discard rate I know was less than 5%. Now, for this particular population, we saw that 70% of them wanted resuscitation and 30% said do not resuscitate. If they wanted resuscitation, it follows logically to yes to intubation and then yes to transfer. If they did not want resuscitation, the picture gets a little bit more complex in that some said, I don't want resuscitation, but I want intubation. And others said, I want resuscitation, but I do not want intubation, which is really the logical component. And so if they did not want intubation, they don't want resuscitation, don't want intubation, but they still want to be transferred. So that basically says, okay, if you find me in my apartment and my heart has stopped, just don't do anything. But if I'm having a hard time breathing, don't intubate me and transfer me to the hospital. And there are life-sustaining treatments that are available in the hospital. The question that might come to mind is this: what if somebody says, do not resuscitate, but intubate? At face value, again, this seems nonsensical, but we looked more deeply into the data and to the response to the types of illnesses that the respondents had. And what we're finding is that these were patients who had respiratory conditions, and they're saying, if my heart stops, don't do anything. But if I need to be intubated, please do. And some of these patients have had experience having been intubated in the past. And they were intubated for short term and then released from the hospital. And, thought, well, okay, if I need to do that again, I'm willing to do that again. So what's interesting in our non-conforming MOLST form is that it allows for more variation in the choices. And the downside is that some of that variation provides us with some nonsensical responses, like resuscitate, which does include intubation, but then don't intubate me. But after resuscitating, some of these pathways just don't make sense. Don't intubate me and transfer, right? So resuscitation includes if they need breathing assistance, whether it's CPAP or intubation, you're going to do it in the field. So I would say that we see some variations that make sense, but we also offer an opportunity to be a little bit more granular when there are, options that are available. The patient
Dr. Chen,
yes?
Dr. Chen, sorry, I actually have a question for you related to that previous slide. The question that came in, is that 70% resuscitation rate typical, or is that unique to that population?
It depends on what you're looking at in the literature. But, this is a setting where patients have typically been in the acute care setting, acute care hospital for 1 or 2 weeks. They're not well enough to be discharged to a skilled nursing facility, and so they're discharged to a long-term acute care hospital. And the patients, the average length of stay for the long-term acute care hospital is about 25, 26, 27 days. Many nursing hours, a higher ratio of patients to physicians than in a skilled nursing facility. And so they're kind of in between the acute care setting and the skilled nursing setting. A lot of them cycle back and forth from long-term acute care back to acute when they decompensate and need acute intervention. For example, they go back to the ICU, and then they come back to the long-term acute care setting. And then about a third of them are discharged to skilled nursing, a third are discharged to home with nursing, and a third, a third go back to acute care. Very few individuals die in a long-term acute care setting because they can do so much. So in terms of your question about whether or not this is typical, there are very few studies in the long-term acute care setting, so we don't know if this is typical for this type of a hospital. And so hopefully others will do more studies, and we'll see if we see the same sort of pattern. Now, the high numbers of resuscitation was not surprising to me because this is a high intervention type of hospital. So by definition, either the clinician who was offering options to the patient offered a number of interventions that are kind of treatment options, and didn't offer palliative care or no intervention as an option, or the patients chose high intervention out of a full set of options that included no treatment or palliative care. Do we have any other questions? Okay, let me move on.
Now, yes.
Okay, let me move on. In terms of patient characteristics, a physician, as opposed to a PA or an NP, signed 62% of the forms that we examined. Oh, by the way, I also want to tell you that this was sequentially acquired forms. So we didn't select forms. We just took them as they came in. So there wasn't any bias in terms of how we selected the forms. I'll talk about a different kind of bias a little bit later. Surrogates as well as patients could sign the form, and 1 in 3 forms were signed by surrogates. That doesn't necessarily mean that this was a invoked surrogate. It could mean that this was a couple and the person in bed says, honey, I'm just too tired to sign it. Can you just sign it for me? So it doesn't necessarily mean that this was invoked. In terms of discharge diagnoses, we see that they were cancers, respiratory illnesses, and cardiovascular diseases. This particular hospital had a vent unit, so it may have had a higher number of folks with respiratory illnesses than other long-term acute care hospitals. And then we wanted to look at the severity of illness. And given that the heterogeneous diagnoses in the population, we thought that it would be appropriate to use a scale that would encapsulate all these different illnesses and give us an estimate for just how sick that particular patient was. And so for those of you who aren't familiar with the Charlson score, you can look it up on the web. It's called the Charlson score, and it's a well-studied research tool that associates chronic illnesses with a number. And it takes into consideration multiple chronic illnesses. And so I'll give you an example. If it's diabetes, that diabetes is assigned a score of 1. If it's diabetes and a history of a heart attack, then the history of a heart attack, history of an MI is also assigned a 1. And if that person has metastatic solid tumors, which is assigned a score of 5, the total score for this person is a 7. And scores above 5 have been associated with extremely high risk of 12-month mortality. Now, this index was created in 1980. When it was created, a score above 5 was associated with 100% one-year mortality. Today, a score above 5 is closer to about 95. It's closer to about 75% one-year mortality. So that's the Charlson score, and you see that the median is 5, and the range is 0 to 12. So how can somebody so sick have a Charlson score of 0? Well, the Charlson score doesn't take into consideration brain injury. So, for example, traumatic brain injury is not captured here. Dementias, those are not captured. So that's why we have. So it's not a perfect score, but it gives us something to work with. If you look at the age, this is totally expected. Most of our sample fell in the range between 60 and 79. If you look, 3/4 of them were above 60. And then we were evenly divided between males and females, and most were non-Hispanic white. So we asked ourselves, how did these characteristics influence the decisions on the MOLST? So 2 out of 3 in our sample chose all treatment. I want everything. I want to be resuscitated, I want to be intubated, and I want to be transferred. And then 1 out of 3 said, I don't want all of it, I want some of it or none of it. And that's the path that someone down that says, I don't want resuscitation, but I want intubation, or I don't want resuscitation, and I do want intubation. So 1 out of 3 went down that path. So we used logistic regression analysis to take into account the factors, the various factors and the various characteristics of the patient. And this is a technique, for those of you not familiar with it, it's a technique that allows us to hold a factor constant while looking at another piece. So we are holding all of these other conditions constant if we wanted to look at the effect of surrogates versus patients. If we wanted to look at illness severity, we're holding everything else constant. In terms of interpretation, the results are expressed as odds ratios, or the likelihood of choosing all treatment. An odds ratio that's greater than 1 indicates that there's a higher odds, there are higher odds or higher likelihood for choosing all treatment than the comparison group. An odds ratio lower than 1 indicates lower odds for choosing all treatment relative to the comparison group. So if I were to choose a simple example, I would say that the odds ratio for males might be 1.5. The interpretation is that males are 50% more likely to choose all treatment than females. If it were 0.4, I would subtract it from 1 and say that the males are 60% less likely to choose all treatment than females. I'm going to go through our findings. This is what we saw. There was no difference between a physician or an advanced practice clinician administered MOLST. We saw no differences in what patients or their surrogates preferred. We looked at forms that were completed by surrogates versus patients, and holding all other characteristics constant, we saw that surrogates were less likely, 40% less likely, almost 50% less likely to choose all treatment than the forms where patients were making the decisions. There is a positive relationship between severity of illness and, it's a negative relationship. So the sicker you are, the less likely you are to choose all treatment. There's an age gradient. Our comparison group was the youngest group. So we see that the older groups are less likely to choose all treatment than the youngest group. And the result is most dramatic for those over 80. And again, this seems to fit logically and probably resonates with those of you who are in clinical practice. Our results show that those over 80 are 80% less likely to choose all treatment than those under 60. We saw no difference between males and females, and we saw no difference between racial groups. I'm going to pause here to let everyone stare at the results for a little while and to ask if there are any questions or comments about these results. Okay, let me move on. So our key findings, we have 3 key findings. Sorry about the typo there. The first is that surrogate decision makers were much less likely to choose all treatment than patients who were making their own decisions. The second is that there's a negative relationship between the Charlson score and a preference for all treatment. So the sicker people were, the less likely they were to choose all treatment. And there's also a negative relationship between the older age groups and a preference for all treatment. I see that someone asked, based on your previous example, 1.5 meant there was a difference. Are you referring to the race? Are you referring to this particular? So these numbers, over 1 means that, there's a higher likelihood for choosing all treatment than the comparison group. This would be male versus females. The reason I didn't point these out is that they're statistically non-significant. And we had enough sample for the male versus female, so I believe this result. We had a very skewed sample. Most of our sample were non-Hispanic white patients. And so if we had a larger sample, we may reach statistical significance with this number. And there are plenty of studies published that show that minorities tend to choose higher intervention levels than the non-Hispanic white populations. So I hope that answers the question about these odds ratios. Okay, so I've gone through this. So this was curious because, with respect to surrogate decision makers being less likely to choose all treatments than patients who made their own decisions. It seemed to be inconsistent with what clinicians felt, how clinicians thought our results would reveal. So clinicians certainly felt that that in their interactions with surrogate decision makers, surrogates tend to want all treatment, or they tend to want more intervention than may be, medically, warranted. And so what I think might be happening here is that clinicians, this might be cognitive bias, and that clinicians remember the cases where they spent the most time, or the cases that were most difficult, or the cases where surrogates were most emotionally charged. So that could be one option, one outcome. The other reason may be that surrogate decision makers and patients who were making their own decisions are inherently two very different groups of people. And that while we tried to hold constant the severity of illness using the Charlson score is imperfect, and that it's possible the Charlson score just did not capture the severity of the patient illness sufficiently. So those are two possible hypotheses. Let me pause again to ask if the clinicians on the phone feel that was a surprising finding, or how their particular experiences may have been with surrogates versus decision makers. Let me talk about study limitations. I had talked about not having selection bias when we chose the MOLST forms, but there really is selection bias because of the population. This was a long-term acute care hospital. These were high acuity patients, and they chose a high intervention pathway. We don't have any information upstream about whether they were presented with a palliative care option, whether they had done prior advanced care planning. For example, we know from literature that if individuals had chosen do not resuscitate in prior advanced care planning documents, that tends to be a pretty stable choice. However, if they chose all treatment in prior advanced care planning documents, then their subsequent choices tend to be unstable and somewhat related to their illness, and somewhat related to the recency with which that individual was hospitalized. The timing of this study was done when MOLST first came into use in Massachusetts. So we know that this was de novo exposure for the patient population to MOLST, and only a very, very small number would have been exposed to a POLST or MOLST in another state. For example, somebody who had moved from Oregon to Massachusetts. They may have, this is a population that might have had advanced care planning documents in place. They might have had living wills, but the large majority did not have them on file, and the large majority did not have healthcare proxies in the medical record. Now that doesn't mean anything because we do know that documentation is quite imperfect there. And the final study limitation is that this is a largely non-Hispanic white sample, and we should not use the data and we should not apply it to a minority group of patients. And in terms of implications for policy and practice, I'd just like to say that the MOLST or POLST is an important tool. It does provide continuity of care preferences in a fragmented healthcare environment. And I say this often, and I hope this is put in practice. The MOLST, certainly our MOLST in Massachusetts, is not just a checklist. It's about the conversation. It's really the documentation and the tool at the end of the conversation that conveys how life-sustaining treatments should be administered or not administered. So I would say training, and training are key. I would hate for the MOLST or POLST to be used as kind of a Dear Mrs. Jones, what would you like type of checklist. I also want to point out here that there are no differences between MD and advanced care practice clinicians. The forms that were administered by MDs or advanced care practice clinicians. And this is important for staffing. And as we move closer and closer to a team approach to patient care, this is an important finding because these advanced practice clinicians were trained at the same time and attended the same sessions as the MDs. So while they may have come up into clinical practice using, under different traditions and through different pathways, at the end of the day, they were trained together about serious illness conversations and about the use of the MOLST forms. And so we found no differences as to who administered them. So that's good news. In terms of clinical practice and talking to patient populations, I would say that I would reiterate that we should revisit goals of care and patient wishes every time there's a change in circumstances or every 6 to 12 months because, patients nearing the end of life may and will change their minds. I've already talked about the stability of DNR preferences as opposed to all care. And we should engage surrogates in goals of care conversations. I'd like to see us engage them as decision partners in the outpatient setting so that when patients enter the inpatient setting, none of this is a surprise. They already know. They've already had the conversations with clinicians. They've already been with the loved ones throughout the, within the last year of life. They've traveled that same road with the loved ones. And then finally, I would say that clinicians might want to consider discussing temporary versus permanent incapacity, and what would patients or surrogates prefer if it's temporary versus permanent incapacity. So I end my presentation here just to say that, again, the MOLSTs or POST are very, very important tools. We don't know what patients want. We don't know how they envision their last days of life. And those of us who do a lot of this research tend to have preferences about certain ways, but I would say that patients don't have, patients have preferences as well, and we should elicit these preferences as they progress in this trajectory toward the end of life. So that ends my presentation. I see that we have some questions, and please feel free to write down your questions, and I'll try to answer them.
Great. Thank you so much for your presentation today. I have a question for you. What are your plans for future research, or do you plan to run this study again?
I don't plan to run this study again in the same settings. I think that future research should capture certain items that are farther upstream of care. I think it's important to gather data from different settings. And if you read a lot of the post research, it's difficult to link them to the EMR, certainly to the EHRs. But once we can do that, they tend to be single-site studies. So it's important that we have multi-site studies, but it's even more important that we capture what happened one step farther upstream. So for example, in the long-term acute care setting, they were discharged from an acute care hospital. What were the options that were discussed with the patients and families when they discussed treatment plan options? Was palliative care ever offered? It's entirely possible that palliative care was not offered as a choice or as an option. We see that in the literature. And so it would be more interesting in future research to capture some of the upstream data points. And this is a particular one that I think is an important one, because there's self-selection into patient sites. Patients and clinicians, basically, depending on what your treatment choices are, we tend to sort people into care settings as a result.
Great, thank you so much. Well, I think we should hold on just for a couple more minutes to see if any other questions or comments come through. I was able to hand out a phone number, so people who are having audio troubles are able to call in. Okay. But if you still have access to your chat box, hopefully that's still functioning for you, and you can go ahead and type in any questions.
I see one. In other post-research studies, surrogates were the decision maker typically when the patient was too ill or incapacitated to speak for themselves. So in other studies, a similar correlation was attributed to the severity of the patient's illness. Yeah, true. In this particular data set, the patients were, I would say, they were not necessarily too ill or too incapacitated. I would not make the leap that all surrogate decisions were made by patients who were incapacitated, because I walked the floors. I was able to observe what happened, and I would say that certainly in the situations that I observed, there were patients who were making their own decisions, but were definitely saying to family, honey, I'm just too tired to look at that form. You're my healthcare proxy, just sign it. I wouldn't say that that's the majority, but I would say that some number of them are in that group.
Thank you. Another question for you, Dr. Chen. How to reconcile when MOLST does not parallel what a healthcare professional requests to have done?
No, I would say that that's, if the MOLST is a more current order, it's a medical order, and it should, that's why I say it's about the conversation. It should reflect the conversation, goals of care conversations between a clinician and a patient or patient family. So I think that the MOLST, it's a medical order. I don't know what experiences that other clinicians have, or what sorts of concerns you have about looking at the MOLST, if the MOLST work, is a recent one and current, and having that taking precedence over other requests. Okay, so I think this concludes our webinar. Thank you, everybody, for joining.
Yep, thank you so much for doing the presentation today. For any other future questions that come up, please email us at admin@pulse.org. And thank you again, Dr. Chen, for your time today. Much appreciated.
You're very welcome. Thank you.
Have a wonderful afternoon. Take care.
Thanks.
Bye.
Bye.